Good morning. Welcome to the maternity piece of this review course. How the day is going to go is I'm Dr. Saplee. I will be presenting the morning information which will include maternity and women's health issues. This afternoon, Professor Gardner will come in and talk to you about the normal newborn and also the high-risk newborn. So for any of the newborn type questions, I'd appreciate it if you save them to this afternoon for Professor Gardner. What we're going to start with is basically the antepartum period, go into the interpartum period, and then into the postpartum period, and finish with women's health issues. Now, women's health issues do cover and go through all those periods of time, but it's just how I'm going to separate them out today to present them. With regards to the antepartum period, the first thing I want to go over a little bit is just the female reproductive system, A and P. Again, in your book on page 536, you're going to see an anatomical diagram of the external structures. On page 537 are the internal structures. Basically, I know you have had these before several times, so I'm not going to go in depth with them. But what I would encourage you to do is just review them, because as I talk about physiologic changes in pregnancy, some of these anatomical structures will so-called be moved around. So again, I would just ask you to review those for yourself. With regards to the pelvis, you will find that the pelvis and breasts are described as well. So again, I would encourage you to just kind of read about that anatomy. The next thing in your book is the menstrual cycle. What you're going to find is that there are charts on page 539. I just want to go through some of the information on these charts for you. Basically, the thing to remember about the menstrual cycle is that there are three types of systems involved. The first one is obviously the system that we're talking about with the anterior pituitary hormones, the FSH and LH, and how they relate to the cycle. You will notice that the FSH and LH are released from the anterior pituitary early in the cycle. They elevate about mid-cycle, and then they decrease after the ovulation period. What you will also see is that estrogen and progesterone come into play as other hormones that are released. Estrogen basically has a double peak, with progesterone peaking after ovulation. The ovarian cycle basically can be divided into two phases. The follicular phase is the early phase. This is the development of the primary follicle up until the time of ovulation, when the ovum is released, and then the luteal phase, which goes from the release of the egg, the absorption of the corpus luteum, into the latent phase of the cycle. The last one is the menstrual phase, and that's divided into the proliferatory phase, which is the beginning of the cycle. And this is really when the lining is really building up to get ready for pregnancy. After ovulation, you're going to see that the secretory phase comes into play, and then the ischemic phase. So the cycle is very complex with regards to hormones, what happens to the uterus, and what also happens to the follicle if the person gets pregnant versus if the person doesn't get pregnant. So again, I would encourage you to review those cycles as you go along. What we're going to go into now is dealing with fetal development. We're going to talk a little bit about the process of gamete formation, fertilization, and implantation. Again, remember that the woman produces one mature ovum. The male produces about 200 to 600 million sperm per ejaculate. Fertilization of the egg or conception usually takes place in the outer third of the tube. And again, remember, it's usually one sperm penetrating the one egg, and that union is known as the zygote. The zygote forms cells and continue to replicate themselves, and this is known as cleavage. Eventually, this becomes a morula, and it becomes a blastocyst, and it's the blastocyst that implants into the endometrium about on days 6 to 10. Chorionic villi develop and extend into the endometrium, and the chorionic villi helps form the placenta and also secretes HCG. And again, with regards to HCG, we're going to know that that's one of the main indicators when we do pregnancy testing. The area of endometrium that holds onto the blastocyst becomes known as the decidua basalis. and the cells continue to divide and mature throughout the rest of the process. So again, you go from gamete formation to fertilization to implantation. With regards to stages, we have the pre-embryonic, the embryonic, and the fetal stages, which I'm going to talk about. The pre-embryonic stage occurs between days 1 to 14. So again, you're talking about once there has been a union between sperm and egg. Fertilization takes place again in the outer 1/3. I've already clarified that. The blastocyst embeds, implantation occurs, and once again, this is a very crucial period with regards to the person either knowing they're pregnant or not knowing they're pregnant. And majority of the women don't know they're pregnant while this is occurring, because obviously it's occurring after ovulation, and the woman would not have missed a period as of yet. All right, upon further assessment, her cervix is found to be 2 centimeters, 80%, and -1 station. She's contracting every 3 minutes. The plan is to administer mag sulfate. First of all, let's discuss that cervix. 2 centimeters, 80%, and what does -1 mean? Station, okay? Remember with station, again, a cervical exam, dilation, effacement, and station is subjective. Again, it's the practitioner is doing the exam. What you're going to find with station is that when you do a pelvic exam, these are the ischial spines. You're measuring the head as it comes down into the pelvis. So once that head is at the ischial spines, we're saying that the baby is at 0 station. If the baby is higher, you do -1, -2, -3. If the baby's head is lower than the ischial spines, you're +1 to +5 before she delivers. So it gives you an idea of where in the birth canal has the baby started to come down at all, or is it what we call ballotable. Ballotable would mean that I do a cervical exam and I touch that baby's head and lift it up, and the baby's head is actually going to just pop up and down like that. So that means to me that baby's head is not engaged, it's not in the pelvis. So for this particular woman, the baby's kind of come down in station to -1. What should you consider, what should your continued assessment include now that she's on mag sulfate? Yeah. Reflexes, okay, so when are we going to do the reflexes? Before you start, great, to get a baseline, and then how often? About every hour, okay? It really does depend on hospital protocol. Some are hours, some are hour to 2, but we can go with every hour. And what are you watching for with those reflexes? See if they decrease, okay? So that's what you're going to watch for. All right, so we know with reflexes, what else are we going to watch her for? Respiratory rate. What don't we want? A dramatic decrease in respiratory rate. Good. What else are we going to watch? I'm sorry? Blood pressure? Okay, what's going to happen to the blood pressure? I'm sorry? Okay, remember there's going to be a slight vasodilation effect with the drug. So again, we will monitor vital signs in general with a person with preterm labor. Another one? Change of mental status. Good. Level of consciousness. Because again, magnesium really tends to put this woman in a state of almost total relaxation, for lack of a better word. So we do have to watch her level of consciousness on this drug. What else do we have to watch with regards to that she's 2 centimeters, 80% and -1 and contracting every 3 minutes? Great. What's her progression in labor? You know, is the drug working? You know, if we go and check this woman in 2 hours, is her cervix still 2 centimeters, 80% and -1, or is it now 4 centimeters, 100%, 0 station? So again, we want to keep track of her labor progress, and hopefully she's not going to go any farther than 2 centimeters, 80% and -1. What education do you need to share with the patient? Yeah. Okay, the question is, do you have to be worried about a person who has, in this particular case, 33 weeks with fetal lung maturity? Yes, you do. So what can we give her? Steroids. Okay, so this is a candidate for steroids. Again, usually they give them up to about 34 weeks. What else? What education do you need to tell this mom? Yeah.
That her anxiety might be a side effect of the medication.
Okay, the anxiety factor can come in from the restlessness she may feel with the medication, but also the anxiety of possibly delivering a preterm infant is really going to come into play. So we need to teach her about that. We obviously need to teach her about what to expect on this medication, and it's nice to do it before you give it to her, because I tell you, when a woman experiences a hot flash from the medication, it's very uncomfortable. So it's easier to tell them up front with any type of patient education what they may expect. The other thing you need to do is with regards to education, you need to talk about the progression of labor, what could possibly happen, and also, basically give her kind of feedback with regards to what you're doing. If you're doing a vaginal exam and you get 3 centimeters, you need to tell her what 3 centimeters means. Again, you're constantly providing patient education.